bayan, ang pambansang awit ng Pilipinas.
Kayang magiliw, kailas na silangalan, alam ng puso, sa dikit mo'y buhay. Lupang hinirang, kuya ka ng magiting, sa manlulupin, di ka pasisikin, sa nagkakaputong sa simoy at sa langit ng pagaw, ay hinatangkod lang awit sa pagkayang minamahal. Ang isang matawad mo'y tagumpay na nag-iingin, ang bituin at araw niya kailan ang ay di matitinig. Luman ang araw ng warhating pagsinta, buhay langit sa piling mo. Aming ligaya na pagkay mga amin, ang mamatay ng dahil sa'yo.
Peace be with you, and good morning once again. I am Dr. Maroon Tunyakaw, your host for this morning. Before we start today's lecture, it is with great pleasure that I welcome the ever dynamic and supportive CEO of Perpetual Soccer Hospital, Mother Zeta Caridad Rivero SPC, for a short message.
Peace be with you and good morning. It's a delight to be here to join you in celebrating another benchmark and shining moment in the life, history, and mission of Perpetual Soccer Hospital. It comes in such a time that Perpetual Soccer Hospital is also commemorating its 85th foundation year. As the theme goes, PSH at 85 must soar above the pandemic, treasuring its legacy of Christ-centered, holistic, and compassionate caring. I start off by saying words of thanks to our distinguished guests, our doctors, specialists, for their innovative excellence and superior expertise. They did raise the bar of excellence in their particular medical practice. I would like to acknowledge Jonald, Lucero, FPCP, FPCC, and Erwyn Novilla, DPBS, who are our speakers for today's webinar. So too, our team of doctors, Dr. Darwin Alvarez, Cardiovascular Anesthesia, Dr. Erwyn Ibanez, Dr. Enrique Posas, Dr. Monico Perez, Thoracic Cardiovascular Surgery, and Dr. Marivic Vestal, Head, Section of Cardiology, Dr. Edwin Chempo, Head, Cardiac Catheterization Laboratory, and of course, Sister Claire Iscanyan and her support team for making possible these innovations to happen in the Cebu Heart Institute. The era of wireless technologies, social media, and video streaming have transformed the clinical landscape, making it a very exciting period for cardiovascular medicine and science. It's really remarkable to think of how far we have gone since we established the Cebu Heart Institute some 27 years ago. And now today, with the endovascular repair, the topic of our webinar. This minimal surgical access provides for lower operative mortality and reductions in the following: stay in the hospital, postoperative recovery time, and invasiveness. These developments in stent graft technology provides us with an improved understanding of how to best treat aortic disease, transcatheter therapies for structural heart disease and cardiac rhythm disorders. PSH has always worked hard not just to deliver safe, quality services on the core values we have so espoused as innovative excellence and superior expertise, but also to level the playing field. This is the first time the endosuture was performed as an ancillary to the EVAR in the Visayas and Mindanao, thus supporting patient access and making available procedures to the populace. We, however, are also called to do much more, from a better understanding of the genetic underpinnings of cardiovascular disease. Thus, we continue to work to ensure that we have the structures in place to create organizational flexibility and unified communication systems, and of course, to support research and education. As healthcare givers, especially in a private Catholic institution as Perpetual Soccer Hospital, we bring to the bedside not only technology and expertise. They are important, yes, but what the patient needs more is tender, loving care, sensitivity, and compassion. Technology is wonderful. It makes access to information unbelievably quick and easy. But mere information is not sufficient to create productive results and produce change. As we wholeheartedly embrace our roles, we too support the development of safe and effective diagnostic and treatment procedures, but always coupled with compassionate caring. Let us take into account our collective human need for communication, presence, warmth, respect, and appreciation, the very qualities that are most threatened by our high-paced and now socially distanced environment. Ladies and gentlemen, over the next few hours, as we learn about these most recent medical advances in our institution, let us reflect in gratitude and appreciation the key roles we assume collectively to make a difference in the lives of our patients and the communities we serve. I am confident that together we will continue to develop rational and sustainable solutions to diagnostics and treatments, as well as continue to train and hone the skills of young medical professionals and encourage each one to extensively go deep into research to achieve better outcomes in the treatment of diseases, especially cardiovascular. Thus, today, as we listen to our specialist in this webinar, we thank the Lord God for the wonders He has bestowed Perpetual Soccer Hospital, made possible by the special persons He blessed us to perform these outstanding deeds. And as we look forward to the future with joy, for more years of PSH loving service, we look back at her colorful story with much humility and gratitude. Perpetual Soccer Hospital's story is the story of how God and His kingdom have been present and operative in our lives from the very beginning. With much trust and assurance, we continue to pray deep in our hearts, constantly saying, "Yes, Lord, Thy kingdom come, thy will be done. Amen. Thank you, and may God bless us all.
Thank you so much, Mother Zeta, for that uplifting message. Before we begin, may I announce our house rules? Please mute all of your microphones. The chat box is open for your queries, and we will have a chance to ask questions to our speakers after they have presented their piece. We are honored to have today the opportunity to hear from our esteemed speakers. Our first speaker had his adult cardiology fellowship training in St. Luke's Medical Global City, interventional cardiology fellowship at St. Luke's Medical Global City. He also had his structural heart and vascular diseases fellowship in St. Luke's Medical Global City. He is an associate professor of Southwestern University and Mahang College of Medicine, Cebu City. He is a head of the Cardiac Catheterization Laboratory, Vicente Soto Memorial Medical Center, Cebu. He is a fellow of the Philippine College of Physicians and Philippine College of Cardiology. He is a member of the Philippine Society of Cardiac Catheterization and Intervention. It is with great honor to welcome our first speaker, Dr. Jonald O. Lucero. He will be discussing endovascular intervention for aortic dissection and transcatheter aortic valve replacement for severe degenerative aortic stenosis. He will then be followed by our second speaker, who graduated Doctor of Medicine at Cebu Institute of Medicine and had his general surgery in Cebu Velas General Hospital, Perpetual Soccer Hospital, and Vicente Soto Memorial Medical Center. He had his cardiovascular surgery fellowship in the Philippine Heart Center and subspecialty fellow aortic and vascular surgery at the Philippine Heart Center. He is a clinical associate, a staff registrar of cardiothoracic surgery of the National Heart Center, Singapore, and is a diplomat of the Philippine Board of Surgery and a diplomat of the Philippine Board of Thoracic, Cardiac, and Vascular Surgery. Ladies and gentlemen, our second speaker is no other than Dr. Erwyn C. Novilla. He will be discussing the hybrid repairs for type B Stanford aortic acute aortic syndromes.
Good morning, everyone. I'll be discussing on endovascular interventions for aortic dissection and transcatheter aortic valve replacement or TAVR for severe degenerative aortic stenosis. I'm Dr. Jonald Lucero. Our first case is about acute thoracic aortic dissection, Stanford B. He's a 51-year-old male who complained of a sudden onset of excruciating chest back pain. He is a former smoker, hypertensive, and non-diabetic, and underwent a CT aortogram, which shows an initial rupture in the thoracic aorta located 2 millimeter distal from the left subclavian artery. Patient opted for TVAR, hence procedure was contemplated, and a Valiant thoracic stent graft was implanted at zone 2 proximal to the left subclavian artery. So the question is, what is aortic dissection? It is a disruption of the medial layer provoked by intramural bleeding. It is a result in the separation of the aortic wall layers and subsequent formation of a true lumen and a false lumen with or without communication. An intimal tear is the initiating condition resulting in the tracking of blood in a dissection plane within the media, identified on non-invasive imaging in 90% of cases and on autopsy in 95% of cases. This is followed either by an aortic rupture in the case of adventitial disruption or by a re-entering into the aortic lumen through a second intimal tear. This can be antegrade or retrograde, and 15% of cases have intramural hematoma. Acute aortic syndromes in aortic dissection are classified according to its etiology and distribution. Class 1, It involves the classic aortic dissection with true and false lumen with or without communication between the two lumina. Class 2, if it has intramural hematoma. Class 3, subtle or discrete aortic dissection with bulging of the aortic wall. Class 4, and there's ulceration of aortic plaque following plaque rupture. Class 5, iatrogenic or traumatic aortic dissection illustrated by a catheter-induced separation of the intima. Aortic dissection can also be categorized according to onset, either acute, diagnosed within 2 weeks of symptom, which has the highest mortality, subacute, who survive the first 2 weeks, and chronic, who survive first 8 weeks. They behave more like aneurysm, rupture is the risk, and malperfusion is uncommon. Most of the patients presents with pain, approximately 95%, and commonly abrupt in onset, usually 85% of cases. And they also present with malperfusion syndromes, approximately 30%, or hypotension or shock, which is commonly seen in 25% of cases. There could also be associated acute MI or ischemia, syncope, neurologic conditions such as stroke, paraplegia, acute renal failure, or a presentation of mesenteric ischemia. Aortic dissection is also classified according to anatomical location. It could be the Bakey or Stanford classification, which is most commonly used. The Bakey type 1 originates in the ascending aorta and propagates to the aortic arch and often beyond it distally. The Bakey type 2 originates in and is confined to the ascending aorta. The Bakey type 3 originates in the descending aorta and extends distally down to the aortic or rarely retrograde into the aortic arch and the ascending aorta. While the most common is the Stanford classification, either a type A or type B. Type A includes all dissection involving the ascending aorta, regardless of the site of origin, while type B involves all dissection not involving the ascending aorta. Type A and type B Stanford classification behave differently. Presentation and natural history depends on the type, as well as its management and prognosis is decided by the type of aortic dissection. The natural history of aortic dissection also differs. Mortality for untreated type A increases in the first week and also on medical management, especially at 1 year, which most of them die 90% in 3 months, while type B untreated cases has a gradual steep compared to complicated type B on medical treatment is another concern. These are the predictors of mortality in acute aortic dissection and complicated type B acute aortic dissection. But in general, these cases are grossly underdiagnosed, even most common and most lethal aortic emergency. Among life-threatening causes of chest pain, aortic dissection has the highest mortality, an estimated of 1 to 2% per hour for the first 48 hours. Still a formidable diagnostic challenge in the emergency department, as many as 65% of aortic dissection cases are missed in the initial exam. Diagnostic delays of more than 24 hours in 39% of cases was also noted. Thus, pretest probability is important to prevent delays and early diagnosis in aortic dissection. These are the high-risk conditions, high-risk features, and high-risk examination features. A low probability if you have 0 to 1 risk group features present, and if you have a high probability if you have a 2 to 3 risk group features or a typical chest pain. If a patient presents in the emergency department with acute chest pain, medical history and clinical examination and ECG should be done, and STEMI should be ruled out. If the presentation really predicts more of acute dissection, then hemodynamic assessment should be done, either if the patient is unstable or stable. If it's unstable, a class 1 indication is to do transthoracic echocardiogram or immediate computed tomography. If the patient is stable, then you try to assess for pretest probability, either low, it has a score of 0 to 1, or high with a score of 2 to 3 with a typical chest pain. Then you follow the algorithm. Imaging is an important modality in the clinching of the diagnosis of aortic dissection, and these are the required details to consider for aortic dissection. Multi-detector computed tomography is the most commonly used modality in the diagnosis of aortic dissection, and its difference with conventional spiral CT is it has a high resolution and acquisition speed of 0.37 seconds rotation speed versus the 1 second rotation speed for conventional CT. And probably the more important aspect is it acquires volume data instead of individual slice data. So what does the guidance tells us in the management of acute aortic dissection? ESC 2014 recommendation for aortic dissection. In all patients with aortic dissection, medical therapy, including pain relief and blood pressure control, is recommended, which is a class 1 level C. In patients with type A aortic dissection, urgent surgery is recommended, which has a class 1 level recommendation. In patients with acute type A aortic dissection and organ malperfusion, a hybrid approach should be considered, which is a class 2A. In uncomplicated type B aortic dissection, medical therapy should always be recommended, which is a class 1, and TEVAR should be considered as a class 2 level B recommendation. In complicated type B aortic dissection, TEVAR is recommended as a class 1 level C recommendation, while surgery may be considered as a class 2B level C recommendation. So why choose endovascular approach in managing aortic dissection? The advantages of endovascular therapy versus open surgery is that it is less invasive, no thoracotomy and no cardiopulmonary bypass is needed. It is less painful, no aortic clump, so less risk for stroke, less intercostal artery coverage, so less paraplegia, shorter hospitalization, feasible in high surgical risk patients, feasible in hemodynamically unstable patients, so less blood loss. The disadvantage, it needs suitable anatomy, contrast-related toxicity, more secondary intervention, and lifelong follow-up is required. In terms of hospital mortality rates, it's around 5 to 9%, stroke risk is 2 to 6%, and paraplegia is 1 to 3%. The principles of endovascular stent graft during acute phase is to prevent imminent rupture and relieve dynamic branch vessel occlusion. In chronic phase, it promotes thrombosis of the false lumen and decreases morbidity associated with the patency of the false lumen, and ability to cover the primary intimal tear and create a seal to stop the flow of blood entering the false lumen and prevent the transmission of systemic pressure across the major intimal defect. The contemporary endovascular treatment technique is to seal the primary entry tear by a stent graft or a bare stent, reperfusion of arterial ischemia using a balloon fenestration or stenting, or you do a hybrid procedure that will be discussed by the next presenter. These are the different stent graft system, and available in our country is the Valiant Thoracic by the Medtronic company. And the indications for use, or the IFU for the Valiant Thoracic stent graft, involves that the iliac and the femoral artery access vessels should be adequate. The non-aneurysmal aortic diameter should be in the range of 18 millimeters to 42 millimeter in cases of thoracic aortic aneurysm and penetrating atherosclerotic ulcer. When there is dissection, it should be 20 millimeter to 44 millimeter. And the non-aneurysmal aortic proximal and distal neck length should be more than 15 millimeter. The contraindications are if the patients who have a condition that threatens to infect the graft, and patients who are sensitive to or have allergies to the device material, or patients who do not meet the criteria outlined in the patient selection guidelines. This is the deployment of the thoracic in the graft.
The Talent Thoracic Stent Graft System features the easy-to-use accelerant delivery system. The accelerant delivery system consists of a single-use, disposable catheter with an integrated handle to provide the user with controlled deployment for accuracy. The Talent Thoracic Stent Graft System is used to treat descending thoracic aortic aneurysms and is a minimally invasive alternative to open surgery. After preparing the accelerant delivery system using the procedure found in the instructions for use, it is important to first locate the radiopaque markers on the Talent Thoracic Stent Graft to identify the location of the connecting bar within the sheath. Turn the sheath to align the connecting bar with the outer bend of the target vessel for implantation. An unaligned connecting bar may increase the likelihood of endoleaks post-implantation. Advance the delivery system through an incision in the femoral artery over the guide wire to the target landing zone. Be sure to monitor the proper orientation of the connecting bar while advancing the stent graft. Ensure that the proximal and distal springs are each placed in adequate landing zones, at least 20 millimeters proximal and distal to the aneurysm comprised of healthy tissue. Initially position the proximal edge of the covered portion of the stent graft a few millimeters higher than the targeted landing zone. Confirm using angiography that the orientation and placement of the proximal end of the stent graft is exactly where you want it to land prior to deployment. Verify that the connecting bar is oriented on the outside of the outer curve of the thoracic aorta. The mid-marker figure 8 indicates the position of the connecting bar. Deploy the proximal end of the Talent Thoracic Stent Graft by holding the delivery system stationary with one hand on the front of the handle and slowly withdrawing the graft cover with the other hand by rotating the external slider counterclockwise. Withdraw the graft cover until the proximal bear spring and the next covered spring have been deployed. Make sure that only the first two springs are deployed before verifying the position. Perform angiography to verify the position of the stent graft in relation to the desired location. If the stent graft was deployed higher than the targeted landing zone, the stent graft can be repositioned distally to its desired location by retracting it, as long as no more than two of the proximal springs have been deployed. To retract the partially deployed stent graft, gently pull down on the entire delivery system until the proximal markers indicating the top edge of the fabric are at the desired position. Do not advance the Talent Thoracic system with an exposed proximal spring, as it may lead to aortic perforation. Verify that the proximal end of the stent graft is placed correctly, and then hold the delivery system steady and continue to rotate the external slider until the distal spring is completely deployed. To remove the delivery system, depress the button on the quick disconnect to retract the tapered tip into the graft cover. Using continual fluoroscopy, watch the top of the Talent Thoracic Stent Graft while slowly pulling back the tapered tip into the graft cover of the accelerant delivery system, re-establishing the smooth transition of the tip with the cover. Hold the tip in place as the whole catheter is withdrawn. Gently remove the delivery system using fluoroscopy to ensure that the stent graft does not move during withdrawal.
The management of type B aortic dissection in terms of complicated type B aortic dissection involves endovascular therapy over surgery, if the anatomy is suitable. There were no randomized trial, but the long-term registry shows that it has lower mortality than surgical approach. This is confirmed by the journal according to the International Registry of Acute Aortic Dissection, and it concluded that TVAR is associated with lower mortality over a 5-year period than the medical therapy for type B acute aortic dissection. While uncomplicated type B aortic dissection, apart from the best medical management, endovascular management or treatment has been tried. The rationale is to promote aortic positive remodeling. And according to the INSTEAD trial, Survivors of type B aortic dissection, TVAR, in addition to the optimal medical treatment, is associated with improved 5-year aorta-specific survival and delayed disease progression. In stable type B dissection with suitable anatomy, preemptive TVAR should be considered to improve late outcomes. And according to the absorbed trial, uncomplicated aortic dissection can be safely treated with a Gortag endoprosthesis, remodeling with thrombosis of the false lumen and reduction of its diameter is induced by the stent graft, but long-term results are still needed. So, let's go on our second case, severe degenerative aortic stenosis undergoing transcatheter aortic valve replacement. Our case is an 85-year-old female hypertensive diabetic which was diagnosed with aortic stenosis since 2016. Her chief complaint was a worsening of EC fatigability for more than a month. Her blood pressure is 140/80, with a heart rate of 60, regular, with a grade 3/6 crescendo-decrescendo systolic murmur appreciated at the second intercostal space, right upper sternal border. And these are her medications. Her 2D echoes showed a severe aortic stenosis with an aortic valve area of 0.72 cm squared, a dimensionless velocity index of 0.2, aortic jet velocity of 4.9 milliseconds, and a mean gradient of 63 millimeters mercury. The ejection fraction by Simpson is 73.5%, and it has a concentric left ventricular hypertrophy with good wall motion, normal RV, mitral sclerosis with moderate MR. Patient has a maximum aortic diameter of 2.5 centimeter or 25 millimeter. Hence, a 29 millimeter evolute R aortic valve was chosen. Patient underwent a minimally invasive procedure, a transcatheter aortic valve replacement, TAVR or TAVI. On the final post-TAVI hemodynamic measurement, it showed that the aortic valve area, the mean gradient, and the maximum velocity improved significantly. So, the aortic valves are normally tricuspid or tricuspal. It has an aortic valve area of 2 to 4 centimeters squared. And the common pathologies are congenital, calcific, which is the most common, and rheumatic. And most common in the elderly subgroups, they present with calcific degenerative aortic stenosis. Hemodynamic progression in aortic stenosis occurs with the interval from mild to severe obstruction, ranging from less than 5 to more than 10 years. Severe obstruction to LV outflow usually is characterized by the following. If you have an aortic depth velocity of 4 millimeters per second or greater, a mean systolic pressure gradient at least 40 millimeters mercury in the presence of a normal cardiac output, and an effective aortic orifice by continuity equation no greater than 1 centimeter squared in an average size adult. The severity of aortic stenosis is classified as mild if you have a 1.5 to 2 centimeters squared, moderate if you have 1 to 1.5 cm squared, or severe if you have less than 1 centimeter squared aortic valve area. According to the staging definition of the severity of aortic stenosis, stage C1, C2, and D1 to D3 are considered severe. In our patient, she is considered D1 because of a maximum velocity of more than 4 millimeters per second, the aortic valve area of less than 1 cm squared, and presented with exertional dyspnea. In theory, ACE inhibitors may be advantageous to the potential benefit effects of LV fibrosis, in addition to the control of hypertension. Beta blockers are an appropriate choice in patients with concurrent coronary artery disease. Vasodilator therapy may be reasonable in acute management of patients with severe decompensated aortic stenosis with NIHAL class 4, and statin therapy is not indicated for the prevention of hemodynamic progression of aortic stenosis. For diagnostic testing and routine follow-up for patients with aortic stenosis is based on the staging. If you are progressive or stage B with mild severity and aortic velocity of 2 to 2.9 millimeters per second, you'll do a follow-up of every 3 to 5 years. For moderate severity, with a Vmax of 3 to 3.9 every 1 to 2 years. If stage C, if you have severe aortic stenosis, then you need to do a routine follow-up every 6 to 12 months. The average course for adults with aortic stenosis is usually a downhill course in relation to age. The older the patient, the severe the degenerative process and the onset of his symptoms, especially with angina, syncope, and dyspnea or failure. In this journal, it showed that severe aortic stenosis has a worse prognosis and lower 5-year survival rate than many metastatic cancer. So again, what does the guidance tell us? The indications for aortic valve replacement in patients with aortic stenosis, especially in our case, if you have severe AS with an aortic velocity of more than 4 millimeters per second with exertional dyspnea, categorized as stage D, then the recommendation is aortic valve replacement, which is a class 1. For patient undergoing aortic valve replacement, surgical risk should be considered either low, intermediate, high, or prohibitive risk. So the STS score of our patient is 5.3% mortality risk, which is intermediate risk, while the Euro score is 2.3%, which is categorized as moderate risk. So the recommendation is surgical AVR for low to intermediate surgical risk. But in the current algorithm for the management of severe aortic stenosis, clinical practice guidelines published in the British Medical Journal in 2016, age is now a deciding factor in choosing what surgical approach would benefit this subgroup of patients. Like for our patient who has low to intermediate surgical risk, with an age of 85 years old, transfemoral TAVI or TAVR over SAVR is strongly recommended. This has also been adopted by the American College of Cardiology and American Heart Association. So what is TAVI or TAVR? TAVI or TAVR is first accomplished in 2002. Initial experience involved transvenous access with transseptal catheterization to gain access to the left side of the heart, and rapidly supplanted by the transarterial access to the femoral artery. It has 2 valve systems during that time which is available, which is the sapien valve and the core valve. This is the deployment of TAVR.
If using the inline sheath without a separate introducer, insert a 14 French introducer over the guide wire into the femoral artery to perform balloon aortic valvuloplasty. Otherwise, insert an 18 French introducer into the femoral artery. Insert dilation balloon through the introducer sheath and advance to the ascending aorta. Give the command to start rapid pacing. Following a significant drop in systemic blood pressure and pulse pressure, inflate balloon. Once the balloon is fully inflated, deflate the balloon and stop rapid pacing. Remove balloon while maintaining guide wire position across the native aortic valve. If using the inline sheath without a separate introducer, exchange the 14 French introducer with the Enveo delivery system's integrated inline sheath, taking care to ensure the sheath is held flush against the capsule during insertion. Stabilize the inline sheath hub once it reaches the vascular access site and continue to advance the delivery system to the target position. Use the actuator to begin the initial deployment of the bioprosthesis. During the deployment process, various angiograms should be taken to ensure proper valve placement. The valve can be resheathed and redeployed to achieve a more optimal implant depth at any point before the point of no recapture, indicated when the radiopaque marker band is even with the distal end of the paddle attachment. Turn the actuator in the opposite direction to advance the capsule until the valve is sufficiently resheathed to reposition and attempt an additional deployment. A valve can be resheathed and redeployed twice before it has to either be fully released or fully recaptured and retrieved from the patient. Withdraw delivery catheter to the descending aorta while maintaining guide wire position. Close the capsule and lock the catheter prior to withdrawing the system. Stabilize the inline sheath and withdraw the delivery system until the capsule is flush with the distal end of the sheath. If using the inline sheath without a separate introducer, remove the delivery system and insert a 14 French introducer to maintain hemostasis. Advance a 6 French pigtail catheter over the guide wire into the left ventricle. Remove the guide wire and connect the pigtail catheter to the transducer. Using both pigtail catheters, record aortic pressure gradient. Remove 6 French pigtail over standard guide wire. Perform post-implant aortogram with the 5 French reference pigtail. Remove the 14 or 18 French introducer sheath and complete the puncture site closure according to hospital protocol. Withdraw 5 French reference pigtail to the aortic bifurcation. Perform contrast angiography of the primary iliac and femoral vessels to document proper closure of the primary access site, as well as the absence of any other vascular complications. Remove the 5 French reference pigtail over a standard guide wire and close access site per hospital protocol.
The complications of TAVI or TAVR involve stroke, heart block, renal dysfunction, vascular complications, and coronary obstruction. CT with 3D reconstruction is an important planning procedure to assess the valve, the aortic root anatomy, and the distance between ostium and the annulus. 3D reconstruction can also help in determining tortuosity, calcification, and other abnormalities. Once you're able to determine the annulus perimeter or diameter, then you can choose the adequate size of the valve for your patient. 2D echo is also an important modality, especially in determining the aortic jet velocity, the aortic valve area, and the mean gradient. TAVR is not recommended in patients with a life expectancy of less than 1 year, even with a successful procedure. Those with a chance of survival with benefit of less than 25% at 2 years is also not recommended. It is also contraindicated in patients with ongoing sepsis, including active endocarditis, recent MI, 30 days, severe mitral regurgitation, severe tricuspid regurgitation, and severe pulmonary regurgitation. It is tantamount to assess any patient according to these characteristics to determine the predisposition for poor prognosis after TAVR. It is also important to remember to always load pre-TAVI meds and institute post-TAVI medication. So what are the clinical trials that support TAVR? One is your partner trial, a US and Canadian multi-center study that lead to the FDA approval of your SAPIEN valve. The primary endpoint is all-cause mortality at 1 year. They enrolled high-risk aortic stenosis patient with an STS score more than 10% and randomized to either TAVR or SAVR. The results showed that TAVR reduced all-cause mortality, cardiovascular mortality, and hospitalization, while the complication involves major vascular and major bleeding and stroke. In conclusion, it said that in severe aortic stenosis patient not suitable for SAVR or surgical aortic valve replacement, TAVR should be the standard of care. It also showed that TAVR decreases all-cause mortality in 30 days. It concluded that TAVR is a viable alternative to SAVR for high-risk patients, and decisions should be made by interdisciplinary heart team evaluation. The other trial is the PARTNER 2. This trial compared safety and effectiveness of newer valve SAPIEN XT. The primary endpoint is all-cause mortality and disabling stroke at 2 years. It compared intermediate risk aortic stenosis with an STS of more than 4% versus SAVR. At 30 days, there's no significant difference in all-cause mortality, and at 2 years, same mortality and stroke was noted. So it showed that TAVR has a major vascular compression at 30 days. The aortic valve area at 2 years was also noted, and moderate to severe paravalvular aortic regurgitation at 2 years. While TAVR, there's life-threatening and disabling bleeding at 30 days. New atrial fibrillation at 30 days, new permanent pacemaker at 30 days, and rehospitalization at 2 years. With the Partner 2 trial results showing non-inferiority with TAVR and SAVR, SUR-TAVI trial came about. It randomizes patients with intermediate surgical risk to either TAVR or SAVR. The primary endpoint was all-cause mortality or disabling stroke at 24 months. The all-cause mortality with TAVR and SAVR was equipoised among the two subgroups, and it concluded that TAVR is non-inferior to SAVR for all-cause mortality or disabling stroke at 24 months for intermediate risk aortic stenosis patients. So now we know that TAVR is indicated to intermediate and high-risk patients with aortic stenosis. But the question is, how about low-risk patients? Does TAVR has benefit for this subgroup of patients? The Partner 3 is a randomized controlled trial for low-risk aortic stenosis patients, but the completion study date is still on December 2021. But the initial 2-year report showed that TAVR compared to SAVR reduced the primary endpoint events, 37% reduction in death, stroke, and CV rehospitalization, but more death and stroke events in TAVR patients from 1 to 2 years, but no significant difference at 2 years. And it reduced CV rehospitalization following TAVR. Thank you.
Good morning, everyone. I would like to thank the organizing committee for giving me this opportunity to talk about hybrid repairs for type B acute aortic syndrome. I have nothing to disclose, so I have outlined this presentation by first giving you an overview of the different spectrum of aortic syndrome. Then I will demonstrate actual cases of type B acute aortic syndromes, and we will discuss its natural history and prognosis, indications, as well as strategies for repair. So these are a spectrum of life-threatening aortic conditions. So This includes your PAU, or a penetrating aortic ulcer, IMH, and the aortic dissection. So there is a marked overlap between these entities, and the most overlap is between an IMH and an aortic dissection. So because IMH, after all, can sometimes represent an aortic dissection wherein you have the thrombosed false lumen with micro entry tears. So IMH as well as PAU can also progress into a frank aortic dissection. So 2 weeks is used as an arbitrary time point to differentiate between acute and chronic condition. So this is based on the mortality as well as complication rate occurring very high during the initial 2 weeks of the illness. So subacute includes patients within the 14 days to 90 days duration. So this was put up by the STS as well as the SBS, primarily because of the therapeutic reason. So it is during this time period that the endovascular repair could optimally achieve a positive aortic remodeling. So briefly, acute aortic dissection is usually initiated by a tear in the intima that allows blood to seep through the wall of the aorta, creating a false and a true lumen. So this is usually separated by an intimal flap. So this is an example with a CT scan of a patient with aortic dissection. So you'll see the entry tear. This is the communication between the false lumen and the true lumen. And the rest of the involved aorta is also separated into true as well as false lumen by this intimal flap. So an intramural hematoma, there's also a separation of the wall of the aorta. However, there is no definite demonstrable intimal flap or tear into the intima. So this is again appreciated in the CT scan, both in the plane and contrast images. So the plane images will show you that the hyperdensity, which is a collection within the wall of the aorta. So again, there is no definite flap. And you can appreciate the relationship of this hyperdensity through the lumen of the aorta in the contrast enhanced image. So a penetrating ulcer actually represents an atherosclerotic plaque that extends into the adventitia, resulting into a surrounding hematoma. So again, this is best demonstrated by looking both at the plane and the contrast images. So here you have the hyperdensity within the wall of the aorta, and looking at the contrast enhanced aorta, you will see this outpouching, which is typical of a penetrating ulcer. So this is the classic anatomic classification, which is familiar to all of us, the DeBakey and the Stanford classification. So the Stanford is more important because of its therapeutic and prognostic implication. So when we say Stanford A, so that means involvement of the ascending aorta regardless of the location of the entry tear. So patients with Stanford A are usually brought to the operating room once they are diagnosed because of the high risk of dying from coronary malperfusion, acute aortic regurgitations, and cardiac tamponade. So type B, on the other hand, follows a more benign course. So the STS as well as the SBS has specified the entry as well as the extent of the aorta by dividing the aorta into the different zones. So zone 0 is the area just before your innominate artery, and so on and so forth. You just be familiar with this nomenclature because the same language is being used when we describe landing zones of the endovascular graft. So our first case, an acute type B aortic dissection with the concomitant saccular aneurysm. So we have a 60-year-old female with severe back pain. Initial chest X-ray showed a widened mediastinum. So subsequently, a CT aortogram was done showing a type B dissection with an entry tear at the left common carotid artery and a saccular aneurysm. So past medical history of hypertension and diabetes and physical examination only showed the slightly elevated blood pressure. So the rest are quite unremarkable. So these are the images of this patient. So CT chest X-ray, you are able to appreciate that widened mediastinum. So the CT scan, the entry tear located at the level of the left common carotid artery. So this is the communication between the true and the false lumen. Then the remaining involved aorta is separated into a true lumen and a false lumen by this intimal flap. So this is also consistent with the 3D reconstruction of this particular patient. So two issues. So you have the deceased aortic arch in the background of dissection. So complete open repair may not be a very good idea. So we utilize a modified frozen elephant trunk for this patient, which I will elaborate later on. So these are the different type of hybrid arch repair. So type 1 arch repair involves mainly debranching the supraaortic vessels and revascularizing them by a trifurcated graft that is attached to the ascending aorta. So in this way, you are able to land now your stent graft into the ascending aorta and effectively treating the arch of the aorta as well as the descending thoracic aorta. So similar to type 1 repair, type 2 repair actually involves replacement also of the ascending aorta with a prosthetic graft. So this is usually employed in patients with baseline dilatation of the ascending aorta. So we're talking about diameters of around 38 to 40 millimeters. So because we have found out that this group of patients are high risk of rupture as well as retrograde dissection whenever we put in a stent graft into the aorta. So in this case, we will deploy the graft into the replaced ascending aorta. So the type 3 repair are the more complex ones. So these are actually typical open elephant trunk technique, wherein you replace the ascending aorta, the arch of the aorta, and by doing the anastomosis at the level of the zone 3. And in this type of repair, we usually leave the cuff of prosthetic material suspended into the descending aorta, which will be utilized as a landing zone in the subsequent TEVAR. So essentially, this is a two-stage procedure. So quite complex, and because of that, a lot of modifications has been made, especially with the availability of the hybrid grafts that we have. So these are example of the hybrid grafts that I've mentioned earlier. So it has two components. So the first component is the typical prosthetic graft, and the other end is composed of the stent graft that is utilized in EVAR. So the the latest modification is the Duraflex device that also provides branch grafts towards the arch vessels. So these are now what we call the frozen elephant trunk technique, but unfortunately, these devices are not available in our country. So that's why we did a modified frozen elephant trunk for our patient. So usually when we do in arch surgery, so it is almost impossible to cross-clamp the aorta because the uninvolved aorta is deep in the chest. So our strategy is to put the patient into a circulatory arrest, meaning the systemic circulation is completely shut down to allow a bloodless anastomosis. And whenever we put the patient in circulatory arrest, we employ hypothermia as an adjunct in order to allow the body to tolerate the period of circulatory arrests. So stroke is the most dreaded complication. So we also employed another adjunct, which is the antegrade cerebral perfusion in order to avoid a stroke. So for this patient, so we have opened up the aorta after inducing a circulatory arrest. So you will appreciate here, so we use the thoracoscope to identify the true lumen. So the field is relatively bloodless. So the true lumen is marked by this suction catheter. And you have that defect in the wall of the aorta, which is the entry tear. And of course, behind that is the false lumen. So here is now our stent graft, which is being guided into the true lumen. So the stent graft is now deployed, and this is the proximal end of the stent graft, which is now secured into the ascending aorta. So the rest of the ascending aorta will be reconstructed using the usual prosthetic graft. And this is the final appearance of the reconstructed aorta. So you have the a trifurcated graft that provides perfusion to the arch vessels. And this one is the reconstructed ascending aorta. Of course, not visible is the stent graft that covers the arch of the aorta and the descending thoracic aorta. So this is the post-operative image. So you can very well appreciate that the trifurcated graft providing perfusion to the head vessels. And this is the usual prosthetic material that replaced the ascending aorta from the sinotubular junction close to the arch of the aorta. So here the stent graft nicely seated in the arch as well as the descending thoracic aorta. So what we have accomplished previously, there is an aneurysm here, so we have effectively excluded that. And take note also of the aorta at the level of the diaphragm. Previously, the false lumen is very much compressed. Now it's starting to expand. So this is a good sign of the potential optimal aortic remodeling in the future. So for the discussion, so complicated acute type B aortic dissection occurs in about 25% of the cases. So this is usually manifested as a ruptured or a malperfused aorta, patients with persistent pain or hypertension, or a rapidly expanding or an aneurysmal aorta. So again, TEVAR is the main recommendation because of the lower mortality compared to open repair. So that's 11 versus 33%. So +1 indication both from the European Society of Vascular Surgery and the European Society of Cardiology. So for uncomplicated type B dissections, best medical therapy. So however, in the IRA data, it was found out that as much as 10% of this patient will die in the next 30 days, and close to 60% will have an aortic expansion in the next 2 years. So the risk of rupture and death is somewhat unknown. So this is the reason why we have identified certain risk factors for patients that would potentially develop complications. And this includes a primary tear that's about 10 millimeter in size, or those primary tear that are located in the inner aspect or in the cavity of the aorta. So total diameter of the aorta, more than 4 centimeter, a false lumen of 22 millimeter, and a partially thrombosed false lumen. So fusiform index about 0.64. So again, these are indications for doing a TEVAR, so +2A recommendation from the European Society of Cardiology. So this is a prevalence of the different risk factors that I have mentioned earlier. So worthwhile to note that the most common is the partially thrombosed false lumen, a dilated aorta, as well as a large inti tear. So as much as 80% will have at least 2 or 3 high-risk features. So therefore, majority of the patients will actually benefit from endovascular repair among those with acute type B aortic dissection. So this is how we do TEVAR for dissection. So because of concern about the fragility of the aorta, so we limit the oversizing to 10%. So the coverage, the goal is mainly to cover the inti tear, so which is most of the time is in the vicinity of the left subclavian artery. So sometimes the proximal end can extend into the arch, where we see a healthy aorta. So if it extends into the arch, you need to debranch some of the arch vessels and do a extra anatomic bypass, which I will elaborate later on. Sorry. So the distal extent is always controversial, but in certain condition like a rupture or malperfusion would tend to be more aggressive. But of course, you always weigh the extent of coverage with the risk of developing spinal cord ischemia. So Pitlicoat is one of the modifications. So in this technique, they use a bare metal stent towards the end of the coverage, primarily to avoid obliterating the segmental arteries that provides perfusion to the spinal cord as well as the visceral branches. So the second case is an IMH with a pleural effusion. So 45-year-old female with severe chest pain, initially dismissed as a musculoskeletal disorder. So it is not uncommon to have a misdiagnosis in the initial presentation. So in fact, in acute aortic syndrome, as much as 40% of the patients are misdiagnosed. So on CT aortogram, so there was an intramural hematoma involving the entire extent of the descending thoracic aorta. and even towards the abdominal aorta. So past medical history of preeclampsia, but no maintenance medication. Again, for physical examination, slightly elevated blood pressure. So this is the CT scan images. So you will appreciate this hyperdensity within the wall of the aorta, which represents a hemorrhagic collection. And you can appreciate its relationship to the lumen of the aorta. So, and again, when we plan for TVAR, mainly because of the fragile aorta. So we must land it again in the healthy aorta, which in this case is in zone 2. So these are the different strategy when we do hybrid repairs involving the thoracic aorta. So the reconstruction always depends on which vessels are being involved. So this figure on the right side shows to you the relationship of the extent of the coverage and the amount of segmental vessels that could be potentially compromised by putting in the stent graft. So in these situations, so other sources of spinal perfusion becomes very important, such as the vertebral artery and the hypogastric artery. So that's why for patients requiring long coverage, it is very important to revascularize your left subclavian artery whenever it is being covered by the stent graft to avoid the paraplegia or spinal cord injury. So this is what was done to the patient. So the marker here indicates the location of the sternal notch. So we created the supraclavicular incision. So through that incision, you'll be able to encounter the clavicular head of the sternocleidomastoid muscles, the anterior scalene, which are all transected in order to be able to visualize the subclavian artery. So potential structures that could be injured are your thoracic duct, the brachial plexus, as well as the phrenic nerve. So here we have already made the anastomosis to the subclavian artery. So we now tunnel the prosthetic material, which is an 8 millimeter Dacron graft, just underneath the internal jugular vein and towards the left common carotid artery. So this is the post-operative image. So you can very well appreciate the patent extra anatomic bypass from the left common carotid towards the subclavian artery. And take note, there is no retrograde flow towards the proximal aorta. So this is very essential because if you're unable to completely obliterate that, you might put the patient at risk for type 2 embolic. So uncomplicated type B IMH are generally managed, again, medical therapy at first, but as much as 70% of these patients will eventually have a failed medical therapy. In fact, 20% will progress into a definite dissection. So they have identified the risk factors. So patients who have resistant arterial hypertension, persistent pain. So maximum diameter of the aorta more than 40 millimeter and the thickness of more than 10 millimeter are important prognosticators. So patients also with pleural effusion as well as concomitant penetrating aortic ulcers. So in this case, again, a TVAR with a class 2A recommendation coming from the European Society of Vascular Surgery as well as the European Society of Cardiology. So how we do TVAR in IMH? So because of the fragile aorta, again, minimal oversizing. So maximum 10%. And the proximal edge needs to cover the healthy aorta. So as much as 34% of these patients will have a zone 1 or zone 2 landing sites. So the distal extent, so most of the time, the intramural hematoma is quite extensive. So you need to balance, again, your coverage to the risk of developing a spinal cord ischemia. So sometimes it's acceptable to put the graft to the area with the thin intramural hematoma, which is about 6 to 8 millimeter in size. So with this strategy, as much as 85% of the patient will achieve a positive aortic remodeling. So the final case, we have a POW in association with the thoracic aortic aneurysm. So 60-year-old male, previously diagnosed with an aneurysm, now presents with the acute back pain. So CT aortogram showed a 6 cm aneurysm in the proximal descending aorta with multiple penetrating ulcers. So in the background of coronary artery disease. So past medical history of hypertension, but poorly compliant to the medication. So physical examination, relatively unremarkable except for the elevated blood pressure. So these are the images, again, 3D reconstruction showing you the saccular aneurysm, which is close to the origin of the left common carotid as well as the left subclavian artery. So in planning TVAR for patients with aneurysm, it is mandatory to have a 2 cm healthy aorta as a landing zone. So in this image, the projected landing zone is in this area, which could potentially obliterate both the common carotid as well as the left subclavian artery. So I have shown this earlier. So different morphologies in doing hybrid repairs to the thoracic aorta. So for this case, our preference is figure C. So we create an extra anatomic bypass to the carotid, then bypass again to the subclavian artery. So B and D are all acceptable. So in the figure D, so this is more of an anatomic bypass that is based on the ascending aorta. So in this situation, we need to open up the sternum in order to access the ascending aorta. So when we construct the carotid to carotid bypass, there are two morphologies. Either you can pass it anteriorly or sometimes retrogradely, but through the retropharyngeal space. So in this type of repair, we usually use a ring of PTFE in order to avoid the compression of the graft. So this is our usual approach. So looking at the patient again, 2 incisions, one in the right side and the other one in the left supraclavicular area. So both the common carotid and the subclavian artery are isolated. So transecting again both the sternocleidomastoid muscle as well as the anterior scalene muscle so that you can access the subclavian artery. So we use the PTFE for the carotid to carotid bypass because our preferred approach is the retropharyngeal space. So this is the 3D reconstruction. You have a very patent graft to the carotid and a patent carotid to subclavian bypass. Again, no retrograde flow towards the proximal portion of the left common carotid and subclavian artery. So again, very essential in avoiding type 2 endoleak. So PAO follows a more benign course compared to your IMH and your dissection. So there is a low rate of rupture, especially if it is asymptomatic, as well as complication because they tend to stay focal, probably because of its association to atherosclerosis and subsequent usual aneurysm. So it could be as high as 3 millimeter per year. And there is no clear association between degeneration to a saccular aneurysm, which is why a CT scan surveillance is enough for this type of patients. However, patients who are symptomatic, those with peri-aortic hematoma or ruptured PAO, PAO that are relatively large, meaning a diameter of about 2 centimeters or a depth of about 1 centimeter. So patients with the baseline dilated aortas more than 42 millimeters tends to be more aggressive, as well as those with concomitant intramural hematomas. So again, TVAR plus to a recommendation both from the ESVS and the ESC. So as much as 20% of this patient will undergo immediate repair. So in conclusion, TVAR is beneficial in certain subgroup of patients with type B acute aortic syndrome, and it should be pursued. So successful intervention requires careful and thorough case planning, and use of hybrid procedure ensures optimal treatment by providing appropriate landing zone. Thank you very much for your attention.
I'd like to thank the speakers for taking time out of their busy schedules to educate us on these topics. Not only did they demonstrate their unwavering commitment to continued medical education, and since we are entering an innovative growth phase in the medical community, their lecture was very timely. The floor is now open for questions for our speakers. Our moderator for today's Q&A is no other than the chairman of the Adult Cardiology Fellowship Training at PSH Cebu Heart Institute, Dr. Marivic.
Good morning. We would like to congratulate our speakers, Dr. Lucero and Dr. Novilla, for updating us on the current innovative endovascular and hybrid repairs of acute aortic syndromes. We would like to remind you that we encourage you to write your questions on the chat box so that the speaker can further elucidate them. Okay, we have for I think any one of you to start the ball rolling. We have residents and nurses here. Could you briefly describe your why do we have to intervene or when do we intervene patients with type B aortic acute aortic syndromes?
Hi, thank you very much, Doc, for that question. So basically for type B acute aortic syndrome, so we classify them based on the complexity or the presence of complications like malperfusion or rupture. So in complicated type, endovascular treatment is really mandatory. However, there are certain subsets who don't have those complications. But then we tend to become more aggressive in those type of patients because what we see, as I've mentioned earlier, as much as 60% of these patients will eventually have long-term complications. What I mean by that, because when we do a long-term follow-up on these patients, we see that the aorta becomes bigger and bigger. So, and they end up to be having some more complicated surgeries later on. So thoracoabdominal surgeries, thoracic aortic aneurysms are very complicated procedures. We have a lot of mortality in terms of purely open surgeries. So that's why we have moved towards preventing these complex thoracoabdominal interventions or open surgeries. So TVAR helps in achieving a remodeling. So instead of resulting into a degeneration in the aorta, you allow the aorta to heal by putting in the stent grafts. So hybrid repairs has become advantageous in the sense that during the planning of the stent graft, we always make sure that the stent graft would land in a healthy aorta. So in a type B acute aortic syndrome, most of the problem usually arise at the vicinity of the left common subclavian artery. And because of this, your stent graft would tend to extend towards the arch. So once it covers the arch, of course, you have a tendency to block those supra-aortic vessels. And because of that, we need to do some maneuvers in order to maintain its perfusion. So that's the reason why we do hybrid repairs. So it's a combination of an open surgery and an endovascular treatment. So before we used to do it in a single stage setting if you have a hybrid operating room, but despite that we have moved away towards the stage procedure because we have seen some complications related to a single stage procedure like patients developing spinal cord ischemia or stroke. So most of the time our recommendation is a two-stage procedure. Then optimally again the graft should be in the healthy aorta. So that's why we combine open surgery along with the endovascular treatment to gain the advantage of both open and the endovascular treatment.
For the sake of the residents, usually medical therapy is the direction for type B aortic dissection. So we decide to do surgery or endovascular procedures for those with complicated, is that right? Complicated type B, Stanford type B aortic syndromes. Okay, would you comment further?
Yes, just like to add on that. First of all, I'd like to thank the Sisters of Charles who really make this event a medical update for all of us. With that question about when are we going to approach those patients with Stanford type B, the recommendation usually tells us that if it's a complicated type of type B, the aortic dissection, so I've discussed it earlier with malperfusion, persistent chest pain, and those patients on an optimized medical treatment, and there is still progression of that problem. Then an endovascular approach, or what we call this structural planning to repair on that entry tear of the type E dissection, which is a more feasible one, which is also recommended in the ESC in the 2014 guidelines that they released, that for complicated type B aortic dissection, it is a class 1 indication that you can do TVAR for these patients.
I have a question for you, Anna. This is regarding TAVR. No? The concept of TAVR was first to offer a valve replacement to patients who are otherwise high risk or has prohibitive risk, no, for surgical aortic valve replacement. So in your one of your flow, no, the therapeutic flow or recommendations for that matter, a cover now is being offered to patients who have low or moderate risk or intermediate risk. So who are the patients or who would be a typical patients for cover in this category?
Thank you, Doc, for that question. We know that aortic stenosis is a progressing disease, and it's been a medical breakthrough when they put this type of approach to patients, especially for those patients who have higher risk for surgery. So TAVR came about during 2002. And for those patients, the real indicated for one is that those who have severe aortic stenosis with aortic velocity of 4 millimeters per second, the most important parameter also that we look is the mean gradient. If the mean gradient is more than 40 or 50 millimeters mercury, then we consider it, and the aortic valve size as well, which is less than 1 centimeter squared. But in the recent guidelines, this tells us that in the partner 1 and the partner 2, which is all about high-risk patients with an STS of more than 10, and in the partner 2, for those patients with intermediate risk with an STS of more than 4, it shows that those patients are now applicable. The approach for TAVR is now applicable for those patients requiring for such a procedure. But in terms, the most important one is that in terms of low-risk patients, as what I've said earlier, is now the battling that we're taking now on, can we do this to low-risk patients? There's no question on intermediate and high-risk patients if there's really an indication, especially when you try to assess the severity of the aortic stenosis. But the question now, the nice question is, can we apply this to low-risk patients? In that partner 3 trial, which still ongoing process, which is the completion date is on 2029, it shows that there are some limitations, but the overall outcome within the 2-year shows that there is 37% reduction in CV deaths and rehospitalization on those patients. So if I will be asked if I can recommend for intermediate to high-risk patients, yes, you can do TAVR or TAVI. But for low-risk patients, we need more data. But the 2-year outcome is a nice one that we can consider in discussing to our patients.
Would you agree, Erwyn, for the low-risk patients, or is it still SAVAR?
Yeah, for low risk patient, actually the guideline is still not very solid in terms of the recommendation. But there's really a role of the TVAR. The one of the advantages of the TVAR, because whenever we replace the aortic valve, we always make sure that we provide the optimal valve for that patient, such that the effective orifice area would be enough in order to respond to the physiologic needs of the patient. So a major limitation in doing an open surgery is actually putting the idea about, especially for patients with very small aortic valve area or very small aortic roots. So that's where the TAVI is more advantageous, because they can always provide us with a valve that has a bigger effective orifice area. Probably a patient selection. So when you see patients with the small aortic root and we anticipate the problem like doing aortic root enlargement in order to be able to implant a satisfactory valve, then I would probably subscribe to the idea of putting in
AVI on that particular patients. But for good risk patients, still open surgery has still a major role in addressing this issue.
So we have a question from our chat box from an anonymous attendee. So doctors, what can you advise for patients with aortic stenosis mild?
For patients who presents with a mild aortic stenosis, the goal treatment is still you maximize your medications for this patient and routine follow-up with your friendly cardiologist and try to assess you from time to time if there is severity or increase in that severity of your parameters by means of doing a regular 2D echogram or transthoracic echocardiogram.
Thank you so much. So we have another question from Dr. Magbuo. Good morning, doctors. I would like to ask if there is a certain size or extent of a thoracic aortic aneurysm that we can consider as unrepairable.
So I'll probably answer that question. So in terms of size and the extent, there's no actually contraindication. We can always provide options for the patient. So may it be a pure open surgery or a combination of an open surgery as well as the endovascular treatment. So nowadays, because of the advent of this endovascular device, the repair becomes more simpler by doing these hybrid procedures. But in terms of size, in terms of extent, the only difference is probably the risk that the patient will undergo. But there's no cutoff in terms of the size as well as the extent. We can always offer options to the patients as to how to best address the situation, considering also the baseline risk to our patient.
Just to add on the statement with Dr. Villa, if you will be asked about which is the maximum size that needs to be done for a surgical or an endovascular approach, the size should be more than 5.5 cm.
Thank you so much. So this is a very interesting question from an anonymous attendee. He would like to ask for the estimated cost for the said procedures that you mentioned.
In terms of costing in endovascular approach, the graph usually is packaged approximately to 550 to 570, 550 to 570,000, which is from the company itself. And I think it's the regional price among Southeast Asian countries that the Medtronic company is offering us. But it depends on of what other devices we're going to use during the whole procedure. Probably that will increase the cost. But the baseline and the regional pricing is around 550 to 570,000.
Thank you. So we have another question here from our chat box from Dr. Zanoria. Doctors, what are your recommendations for patients with asymptomatic severe aortic stenosis?
For patients with asymptomatic severe aortic stenosis, I think one of the guidelines tells us that these patients should undergo stress evaluation. One of the stress evaluation that was recommended is doing the vitamin stress tests for these patients, try to see if these patients really improve or if these are candidates for TAVR or TAVI.
Thank you so much, Dr. Lucero. We have another question here from an anonymous attendee. Peace be with you and good morning. How can we prevent aneurysm to occur? And for patients with heart problems, can they also receive COVID-19 vaccine?
I think in terms of prevention, so ang most common association between aneurysm and mga risk factors is actually smoking. So probably encourage everyone to, if you're smoking right now, probably stop smoking because these are really the strong association. But there are some risk factors that could not be modified. Like for example, genetic predisposition, patients with Marfan's, Ehlers-Danlos syndrome. So you can't do anything about this condition. So probably a modifiable is smoking. Then the rest probably you could not really avoid it because some of these are also related to atherosclerosis, which eventually develops over time.
With that one, just like that, I agree with Dr. Novilla that one of the risk factors is smoking. And in terms of this progression of disease, either in an intrarenal or thoracic aneurysm, age also is a determining factor. The more young are you, as they say, elderly, then the risk of having progression of that disease. No, the other one is that you have family risk factors or a genetic predisposition. And down the line, if you have hypertension and atherosclerosis as a risk factor. Then in terms of vaccination, patients who underwent endovascular repairs, there's no contraindications for vaccination for COVID vaccine.
Thank you so much, Dr. Lucero and Dr. Novilla. We have another question here from our chat box. So in patients with comorbidities, such as those with stroke and recent myocardial infarction and heart failure, can we still do the procedures?
Yes, in those situations, in terms of aneurysm repair, so TVAR has really a role in those situations. So, and TVAR is really established when it comes to thoracic involvement. So, proven over time compared to open surgery, they are really superior. But there are situations that TVAR could not be used. So, for example, involvement of the ascending aorta. So in those scenarios, open repair is the only choice. If you have a dissection, you have to bite the bullet, you know. So that's the only surgery is the only chance of for this patient to survive if they have acute aortic syndrome. So you'll just have to manage the risk.
So with that one of the important factors also is to do this is in a multidisciplinary approach. We need to call our friendly neurologist to help us assess. But in terms of the annals of the neurology, they shows that if it's really needed to do this procedure, at least a 30-day would warrant for it. But the recommendation in most of the annals in the neurological journals tells that around 3 to 6 months would be the waiting time.
We have one question from one of our residents here in Perpetual Soccer. So she said, "Good morning, doctors. Thank you so much for that very insightful discussion." She would like to ask regarding post-op care for patients who underwent TVAR. As residents, what should we watch out for or monitor in the first 24 hours to 1 week after the procedure?
Well, I guess very important and devastating complication is spinal cord ischemia. So even with open surgery involving the thoracoabdominal or the thoracic aorta, this is a fairly common complication. So even with the TVAR, we have not actually significantly cut down on this complication. So very important. One distinct presentation for TVAR, unlike open surgery, some patients could even manifest paraplegia or spinal cord ischemia in a delayed fashion. So it develops 24 hours, 48 hours after the operation. So you need to watch out, monitor the patient. So very essential in preventing spinal cord ischemia. So it's always a balance between the perfusion pressure and the increase in the intrathecal pressure. So how to strike that balance? Of course, you maintain a high mean arterial pressure to increase the perfusion. And another way is to decrease the intrathecal pressure. How do we do this? So if you see patients developing paraplegia during the immediate perioperative period, you can either put in a CSF drain. So you drain the CSF, maintain a CSF pressure of around 10 millimeters of mercury, optimize your mean arterial pressure to about 90 millimeters of mercury. Then some of these patients will the paraplegia would reverse. So it's really picking up the patient early. Then anticipate this complication, especially when you're covering extensive portions of the thoracic aorta, wherein you will be compromising a number of the segmental arteries. So you can either put the CSF drain prophylactically, meaning before even putting in the device there, and monitor the CSF pressure and keep it at a low level, so around 10 millimeters of mercury, then maintain the systolic pressure, again, at least 90 millimeters of mercury. Another common complication is lymph ischemia. So sometimes your graft can be folded, resulting into lymph ischemia. So lymph ischemia could also be related to access complications because we open up the femoral vessels to these patients. So we repair it after the surgery, and most of these patients they have atherosclerosis as a background disease. So sometimes manipulation during the catheter maneuver, during wire maneuvers, you could really potentially dislodge this atherosclerotic plaque. So they can cause emboli. So basically, important monitoring is to check on the pulses of the patients from time to time. Then stroke, of course, is one of complications, especially when you are doing arch interventions, because plaques in the arch of the aorta can potentially go into those arch vessels. So the rest are usually diagnosed mga later complications like the indolic, which usually we pick up those patients. We most of the time indolic unless it's not the type 1 or the type 3. Most of the time we just monitor these patients. So I think those are the major na fearful complications in the immediate na perioperative period. So cord ischemia as well as limb ischemia and stroke.
And to add on it, for the resident, if you see patients post-operatively and with those type of procedures like endovascular or surgical approach, then the most important is try to get the basic laboratory tests when you see the patients or when you receive the patient, like you do a repeat CBC, try to see if there's decrease in the hemoglobin or there's signs of bleeding, then try to get the electrolytes which predispose to arrhythmias. And most importantly, try to monitor the dorsalis pedis artery if it's a bounding pulse, because that's what Dr. Novilla said. We will be occluding the distal flow through the catheter, and probably that occlusion probably predisposed to probably an acute limb ischemia in the setting. But most of our patients doesn't shows any kind of, but it's prerequisite that we always monitor the dorsalis pedis artery. And as what Dr. Novilla also said, that neurological assessment is a very important parameter post-op of these patients.
Thank you so much.
We have a question here which is relevant. Can we do these things that you have lectured here in our center?
I think I will go first before Dr. Villa. Yes, it's a very big yes, because the SPC and the PSH already invested a very big and a very nice device modality that is already in our institution. It acquired the new Philips Azurion 7 Flex Arm, and it also included some of the latest gadgets, which will really assess in terms of endovascular or coronaries. In terms of coronary assessment, they already instituted the intravascular ultrasound, and we have also a device that can determine the physiologic status of those coronaries, which is the instantaneous wave-free ratio, or the IFR, and the fractional flow reserve, which is the FFR, which all of these modalities are available. And if you're gonna ask me, these modalities are only available in this institution in Perpetual Socorro Hospital. It's not available in any centers around Cebu or even in Mindanao. But there is a company that can support with this if you need one. But in terms of if we are capable with the contemporary with Dr. Novilla is around, I think we are now capable and ready to do these procedures in a manner that we can say to our patient how safe is this, and the outcome will be the same or beneficial for them.
Yeah, in addition to that, it's a big yes. So we have all the facility that is available. We have a nice cath lab wherein you can do the endovascular component. Then beside our cath lab is our operating room. So whenever we have any problems, we can always bring the patient to the operating room. But we seldom see a conversion or immediate intraoperative complications related to endovascular treatment. very important is the case planning. So it is always a joint decision between surgeons as well as interventionists. So we need to we need to review the images, because the TVAR mainly relies on the anatomy of the patient. So because imagine when you're doing open surgery, we suture the graft, but this you don't suture the graft. So the graft relies on its radial strength, meaning the graft has a natural tendency to expand, and it is this and it is this property that fixes it to the aorta. So unlike the open surgery that we really put on the sutures. So basically, the planning is very important. So we tend to the oversizing of the graft. There are very important factors in deciding what is the ideal graft. Then of course make sure that the aorta is healthy, because if you land it in the unhealthy aorta, over time that aorta becomes dilated, then problem starts to come in. So you will develop eventual type 1 indolic, so the sac will be pressurized eventually. Then you can predispose still the patient to rupture. So I think a joint endovascular team is really a good setup. So we need to discuss cases in collaboration with the cardiologist, the surgeon, regarding the indications, the ideal implantation, and of course consider the patient primarily. So consider the risk factors of your patient.
And just to add on it, in terms of our institution now with Dr. Novilla and I already around in perpetual soccer, I think we're now putting up what we call the structural heart team. I think this is a best program that we can offer to our patients, because this will be a multidisciplinary approach, and there will also other subspecialties that will be called, especially if we need them from time to time.
Thank you so much. So we have another two questions from our chat box. So good morning, doctors. Are there any specific lifestyle changes that these post-op patients should observe? Are there any prohibited physical activities?
In the first month of post-endovascular repairs, either you do an infrarenal EVAR or a thoracic TVAR, and we usually recommend our patients to do what we call this symptom-limited exercises, and we usually refer them to cardiac rehab. And for limitations, one is the most important, or secondary prevention, is we always tell our patients, if you're smoking, then you need to stop smoking. If we need to control the hypertension, the dyslipidemia, if you're diabetic, we need to control the sugars. In terms of risking, or probably the question is, I think we'll just revise the question. If you were afraid that the graft might move downwards from its placement, then it is less likely, because once the graft almost a month or a week, it will be endothelialized. So the risk of movement. But in terms of the anatomy, that's from case to case basis. We tell our patients what would need to be monitored and what would not be done during those times when he will be going back to his home. In terms of activities, we just tell our patients in a manner that moderate activity can be done.
Thank you so much. So we have a question from Dr. Marjorie Arong. When is TAVR a better option for stenotic DAV over SAVR? When is TAVR a better option for stenotic DAV over SAVR?
You mean a bicuspid aortic valve? Okay. There are recent studies that is TAVR really recommended for bicuspid aortic valve? There's a recent study that published 2 years ago that shows that TAVR is a good planning for patients with bicuspid aortic valve, especially from the question that Dr. Arong stated, it's for stenotic one, because there is a good grasp when you deploy that valve. But the question now would be like, if you have a bicuspid aortic valve with severe aortic regurgitation, is TAV indicated? In some recent journals, that approach is a little bit become a limitation, because there's nothing that the crown of that valve can grasp on. So TAVI should always be a planning planning for thinking of where would the crown attach to the, especially to the annular plane. For TAVI, a better planning is the better attachment if there is more of calcification rather than if you can see any calcification, because it will not hold on any tissue around it. But for stenotic because with the aortic valve, TAVI is indicated.
Thank you so much, Dr. Lucero. So we have another question. The anonymous attendee would like to ask you if you could expound more on the prognosis of the said procedures, and will the benefit outweigh the risks?
Well, you mean in patients with acute aortic syndrome. So basically dissections, intramural hematoma, and PAU. So when it comes to PAU, very good results. So the stent graft could stay there, and it would effectively prevent rupture or any complications. Ang problem is patients with acute dissection. So because we have found out that the remodeling, the aortic remodeling, is directly related to the segment of the aorta that is being covered by the stent graft. So it's not really so I have mentioned earlier that the main goal is to cover that entry tear. So once you cover that entry tear, it doesn't always follow that the rest of the dissected aorta would remodel positively. So there are instances that the remodeling would be restricted to the area where you have the stent graft. So that's the problem with the dissection. That's why I have seen I have demonstrated some of the innovations wherein they become more aggressive in terms of the coverage. So meaning to say you cover the entry tear, then apart from that they tend to put some extension that doesn't compromise much of the segmental pressure to the spinal cord as well as the spinal vessels by putting in bare metal stents. So ang balance is ang remodeling is always parang they become proportional with the amount of the aorta that is being covered. So most of the patients, especially sa acute dissection, as much as 30% of these patients would eventually develop aneurysmal degeneration, especially involving the abdominal aorta. So this is one of the complications that would later on develop. So that's why, despite doing a TVAR or endovascular repair in these patients, you need to monitor these patients long term. So petticoat, as I mentioned earlier, is one of the innovations wherein they extend with a bare metal stent. So we're looking at the data with those technique.
So we have a follow-up question. Actually, this was answered earlier, but Dr. Rosca would like to know the average cost of the procedures. I think this is inclusive of the PF and everything else.
For Endovascular, just gonna repeat this one. It's more of a company price that the company is offering us. It's around 550 to 570,000 for the cost of the grafts. But if you have additional procedures that you need to put on, and probably that will increase. But the graft size is even how many grafts you're going to use or going to attach to the patient, it is still be at a fixed price at a 550 to 570,000. The package is usually, for the two cases that I've done in the endovascular aortic repair, we usually quote our patients around 1.5 to 1.8 million.
So yeah, roughly the ballpark figure is around that area. So ang major which is a bit costly is the device, because as of now we only have one provider. So probably over time with the appearance of, or with the acceptance of the other devices, probably we can cut down on the prices, and I think more or less may ana siguro na figure.
Just like Danet, it's still case-to-case basis, because if you will not like the two cases that we have done in our institution, we use endosutures because of the hostile proximal neck. And we need to occlude the internal iliacs and put a coil. So that one really increases the cost. But if it would be a straightforward endovascular repair, and usually the Medtronic company fixed price and probably the professional fee and a little bit of the hospital cost would just be around less than $1 million.
So are there any more questions from our chat box? So if there are no more questions, and before we end our fruitful morning, may I call on once again the chairman of the Adult Cardiology Fellowship Training and PSH Cebu Heart Institute, Dr. Marivic Vestal, for her closing remarks.
The Perpetual Soccer Hospital today is a far cry from its humble beginnings 85 years ago. While the charisma of providing optimal medical care to the community it serves remains, the hospital has evolved with time, not just infrastructure, but also always striving to be current with medical innovation. We always have Mother Seta and the SPC sisters to be thankful for. Mother Seta is a rare mix of a visionary, a mover, a doer, and a builder. The section of cardiology, cardiologists and cardiofellow alike are in high morale. You have provided us with a top-of-the-line Azorion 7 cath lab system and updated our cardiac surgery facility that we can now do structural interventions like TAVR, TVAR, and EVARs, and even hybrid surgeries. As an add-on to the usual revascularization procedures that we are always doing, the bypass surgeries and the angioplasties. Together with Dr. Jonald Lucero and Dr. Erwyn Novilla, we have Dr. Edgar Molino, Dr. Edwin Tiempo, Dr. Florante Lumibao, Dr. Monico Perez, Dr. Sam Yadaw, Dr. Jonathan Aldo, and our cardiac anesthesiologist, Dr. Darwin Alvarez. We also have Dr. Rudy Amatong, who has been doing device interventions for ASDs and PDAs for both pediatric and adult congenital patients. We can say that we have a cardiovascular surgeon and cardiovascular interventionist who are working strongly as a team. We are all beaming with pride that we now have the facility and the expertise to offer these innovations to our patients. And in the celebration of the 85th anniversary of the foundation of the Perpetual Soccer Hospital, we are, with this innovation, taking a step higher towards bigger strides. We thank the organizing committee for this webinar, headed by Sister Gao, Sister Claire, Sister Rochelle, Joy, Earl, and Maroon, as well as the technical staff. So let us celebrate us. PSH at 85, thank you, and have a good day.
Oh,